to be talking a lot about my usability and human-centered design work, but I cut a lot of the demonstrative visual assets out of the presentation. So if anybody wants to see some of the more visually intriguing parts of the presentation, we can go back and look at it.
Thank you. That would be helpful. And then just to let you know, I don't know if MJ said, Sarah Knight, who's on, will be presenting a little bit about our series. This is a relatively new series, so congratulations, you're one of the first. You're like the standard bearer here. And then MJ will officially introduce you. This is a new time for this kind of thing, so there may be, there's not going to be hundreds of people on the call, but hopefully we have a pretty good crowd for you.
I'm waiting to let them in until you guys talked. So just let me know when you're ready to start and I'll start admitting more people.
I think at this point, just start admitting people
Okay.
And then I'll shut up. We'll shut up.
Okay.
Yeah, Adam had a very bad experience with a meeting getting banned, Zoom banned, which cautionary tale. Oh, hey, Greg. How's the weather in Florida? Oh.
You weren't asking me that question, were you, Matt?
No, I was asking Jolie.
Oh, I'm sorry. What did you say?
Oh, how's the weather in Florida?
Nice. It's always nice. I mean, who can complain?
Right.
I can still take walks at night and not freeze. But you know how Florida is. If it gets below 72, we start complaining that it's winter.
Right.
Just to be clear, you would like my presentation stop time to be at 1/4 till, is that correct?
Yeah, it's up to you. I mean, I think if you have, 15, anywhere between 0 and 15 minutes, we do have this natural thing afterwards that we can, we actually do further discussion. I think most people will probably only have an hour though.
Okay, so you have a choice. I can stop in between sections and allow for discussion, or I can just go through. Sometimes people like for presenters to stop because
Totally.
By the time you get so far into a presentation, you forgot what you were going to ask, or it seems mute. So I can actually stop throughout, but that might leave less time if we do discussion throughout.
Totally okay, whatever you want to do. I think we better get going because it is a minute after. So,
okay.
Sarah?
Great, thanks, and welcome everyone. This is our inaugural meeting of Utah's Forum on Advancing the Theory and Application of Implementation Science. We are seeking to disseminate the latest novel research regarding theory, practice, and application of dissemination and implementation science. And we're very excited today to start what's going to be a regular and I think quarterly series, although we may have more frequent special presentations as well. And we'll usually start with a presentation from a nationally and internationally known speaker. And then at the end of that presentation, we'll add on a half hour of tea time for people to have a cup of tea and to chat with the presenter about things like how did they become an implementation scientist? And what kinds of training do you need to get? So intended to be for early career investigators, but also any people that want to enter the field of implementation science and implementation research more generally. So thanks so much for being here. And MJ, would you take it away with the introduction?
Absolutely. So good morning, everyone. It's my pleasure to introduce Dr. Jolie Haun, who I've had the pleasure of knowing and working with over the past few years, which has been actually quite fun. So Dr. Haun is a supervisory research health scientist and director for implementation and dissemination research at the James A. Haley Veterans Hospital in Tampa, Florida, where it's warm and there's no snow, and there wasn't just a snow dusting guy coming out and clearing the road. So she has implementation science expertise in participatory mixed methods, human-centered design, and she's going to show some of this, which is super cool, and systems redesign strategies. And she also has interests. Her interest really flows in the areas of health information technology, complementary and integrative health, and health literacy. Dr. Haun is an interesting combination of research that's focused on addressing users' uptake and sustained use of virtual health resources within the VA. And she also works with health services research, research and development, and the Quality Enhancement Research Initiative on funded research. That's 3 out of like 5 different services in VA. So she's got broad funding in VA. And she also works with VA operations and clinical groups, which I think is what makes her research so, it makes things move faster in the clinical realm. She's nationally recognized for leading interdisciplinary efforts to implement, evaluate, and redesign electronic web and mobile-based health IT systems. She has over 40 professional peer-reviewed publications and over 50 professional presentations. And her research has led to the production and dissemination of 17 direct-to-consumer training and educational multimedia products. While Dr. Haun is focusing this presentation on mobile health research and applications, she has additional research projects, including one that we submitted together to VA Health Services Research last week. So take it away, Dr. Haun.
Thank you. So thank you for that introduction. And as MJ mentioned, I have a diverse portfolio where I focus on different topic areas, but I was asked to focus on my virtual health implementation science program for today's presentation. So I'm going to share my screen and start the presentation. Hopefully, there we go. Okay. Can you see a presentation slide?
Yep, looks great.
Okay, great. So today we're going to talk about promoting a culture and a system of virtual healthcare through implementation science. And this is something that I've been doing for the last 10 years in the VA. I'm going to give you an introduction to my background, an overview of my research approach, and we're going to talk about my work, completed, current, and proposed, to give you an idea of the kind of transformation that not just I have gone through as an implementation scientist, but what we've seen happen in virtual health in the last 10 years in the VA, which has been a very exciting decade for the VA as far as virtual health goes, especially with this year. This year has been extremely unique and fun. So who am I? Well, as she mentioned, I'm the Director of Implementation and Dissemination. I'm a supervisory research health scientist at James A. Haley. I am a PI with a team of about 15 interdisciplinary professionals. I've got, I think, something like 5 PhDs on my team and several master levels researchers that run approximately 10 projects that we have. And I'm affiliate associate at the College of Public Health. And it doesn't seem relevant, but it is, because I was a licensed massage therapist since 1995. And I actually did my postdoc at the University of Arizona in the College of Medicine in whole systems research. And so this was something that I've been involved in for a very long time. My first research that I conducted was in hematology and oncology, and the impacts of massage therapy with that population. But it kind of went away, but then it came back. So we'll talk about that a little bit, especially as it pertains to virtual health. As far as funding and partnerships, I think it's notable that I have a very diverse portfolio with our R&D, which is rehabilitation research and development, health services research and development, and query, which is kind of the funding for implementation work in the VA. I have a significant amount of operational funds from the Office of Rural Health and the Office of Connected Care because of the work that I do in virtual health. And then it's a side note, but it's also notable that I have a significant amount of clinical funding from my hospital out of Whole Health Service, which is Whole Health. When I say that, is VA's version of complementary and integrative health and medicine. And what's interesting about that is that I wouldn't talk about that for virtual, except for the fact of several of my projects are about the delivery of complementary and integrative health using virtual resources. So we will dabble in that just a little bit for today's discussion because it is relevant. I have a significant number of operational partnerships, as I just mentioned, and clinical partnerships are the key to my work in implementation. Every single project that I have that is funded has a least one or more clinical co-investigators. Oftentimes they are chief of staffs of primary care or nursing. Sometimes they are out of VISN, which is the regions of the VA. So we have a lot of partnerships, and they often start with the conceptualization of my projects and move all the way through publications. So if you look at my publications, you'll note a lot of individuals who aren't particularly funded researchers, but they're professional clinicians who participate throughout the process of my work. You'll also note that with my work as well, with the operational partnerships, they play a key role. I would like to say that I drive my work, but the truth is my operational and clinical partnerships are more of the driving force of my work, honestly. Okay. So I'm going to tell you about something that's an old story, but it's kind of the key to who I am and why I'm here. When I did my doctoral studies, I was my specialty was health literacy. And for my dissertation, I validated a 4-item screening tool in the clinical setting because a lot of the tools for health literacy were only looking at particular constructs. They were not looking at health literacy as a holistic construct, and also they were not user-friendly in the clinical setting. So I ended up validating this tool in the clinical setting of the North Florida, South Georgia VA. And through my clinical partnership, I worked with operations and we ended up getting it implemented into the electronic health record in North Florida, South Georgia. Long story short, I went to go get my postdoc, and for 2 years I was gone before I came back as a VA scientist. And by the time I got back as a VA scientist, they had screened the entire North Florida, South Georgia population of 112,000 veterans. When I came back as a scientist, one of the first things I did was grab that data set along with 3 years of data for cost from 2007 to 2009 for 92,000 of the 112,000 veterans that had costs for those 3 years. And we ran a cost association analysis. And what we were able to determine was that not only had we effectively put the screen into the electronic health record and screened the entire population, but we were able to evaluate the associated costs, which in that 3-year time frame, the individuals with marginal and inadequate health literacy had an estimated cost of $143 million over those for the individuals that had adequate health literacy. This ended up being published and became a seminal paper in the field of health literacy and is often cited to demonstrate the effects of inadequate health literacy. We received a National Patient Safety Award from Pfizer for this work. It ended up creating a grassroots spread of the implementation of this tool throughout the VA. And at the same time, the kind of godfather of health literacy, Michael Pasch-Orlow, got NIH funding to create a health literacy tool shed, which housed all of the measures of health literacy. I get approximately 3 inquiries a month from all over the world about the permission and the demonstrated use of this tool. It's been translated into several other languages, and it is probably some of the broadest and most disseminated work that I've done in my career. Well, I just have to tell you that it got me hooked. I became hooked on implementation because I saw the power of not only science, but what happens when it gets implemented and disseminated. And I also discovered the power of the electronic health record and how it could be used to support not only our work, but to support care and to meet the needs of patients around the world. So that was it for me. Implementation science was my path from there on. So that's how I became Dr. Jolie Haun and why I'm an implementation scientist in the VA. So let me talk to you really quickly about my research approach. Does anybody have any questions before I move on to the next section? Just remember, you might be on mute. Okay, we'll move on. Matt, you're talking?
Okay, yeah. All right, as long as I feel like someone should ask a question, so I'll get it started. So was any intervention done to address health literacy, and what was the evidence that there was actually a causal effect on cost? Can you speak to that? So there's two parts of the question.
So basically what we did is we did an association analysis between the so the tool itself ranks people to 3 categories. Your scoring intervals will either indicate that you have adequate health literacy, marginal health literacy, or inadequate health literacy. So what we did is we took these 3 cohorts and we ran analyses of their cost over 3 years and looked at the cost difference over those 3 years. So of course, there could have been some confounding variables that could also have influenced those costs. But for the most part, you're looking at a population analysis, not a sample. And we controlled for different types of, like, for example, DCG scores, so on and so forth, where we accounted for any cost or disease specific variance that may influence that outcome. And then we did the analysis, and it was very clear that the cost difference was quite different on their annual expense for a system. And we did inpatient, outpatient, and emergency, the big ones that give you your general cost equivalent. And then we looked at the differences. And then once we got the differences between each group, it's a simple calculation of how much more the inadequate and marginal group was, and then the multiplication times the number of individuals in each of those groups, which is really interesting because it wasn't a very large percentage that had marginal and inadequate health literacy. However, their costs were so great that it accounted for a major cost difference, which we've seen this in samples. There's a Georgetown University sample study that was done that was previously kind of the seminal paper that demonstrated the association of impact as a result of inadequate health literacy. And it was almost it was very comparable to what they found. We just found it in a much larger group representing an entire population.
Yep.
Okay?
Yep.
So my research approach. So here's the value proposition. When I came in to the VA, it was 10 years ago, and secure messaging was on the scene. The VA was the leader in the electronic health record. My Healthy Vet was starting to pick up in popularity, but wasn't the norm, and most certainly wasn't the norm across all healthcare systems, except for maybe Kaiser. And so we were really trying to establish what the value was. And obviously the dream was to have greater access and more efficient delivery of care, to create proactive patient-driven care, to increase patient engagement, to have an effective distribution and access of resources, and to be able to associate the use of these resources with a quality of healthcare and outcomes. So this is kind of what drives my work. Theoretically, and this is something that's happened over time, we all know that in implementation, RE-AIM has been a good framework that's been used for a long time to have an evidenced systematic approach for planning and implementing programs over time. So this is really helpful. And then within that framework, I use the conceptual framework for implementation research to identify and contextualize the constructs of interest at each phase of implementation within the RE-AIM model. And then when you're starting to understand what the benefits and barriers are, what the factors of interest are, then you start to identify implementation strategies, which most commonly I would reference and go to Powell's implementation strategies, which is very common among implementation science, to kind of identify what can be done to be responsive to what we're seeing in a given project and how we can support uptake and overcome barriers. I think it's really interesting to note that as a virtual health scientist, Powell did not adequately address implementation strategies for virtual implementation. And so the work that he did, or excuse me, that they did, does need to be adapted and modified to some degree to be applied to virtual science. As far as methods, I am a mixed methodologist. Almost all of my projects have some qualitative and quantitative aspect to it. But a lot of times with my implementation science projects, I used a participatory method called human-centered design. And the reason why we do this is because a lot of what I'm implementing is something that will have targeted users, be it the veteran, the patient, the healthcare team member, and or caregivers, which is something that is a more recent development in the VA and is something that I'm working with now. So I have 3 primary audiences that I work with. And so we want to use human-centered designs to take an empathic and exploratory approach to creating something that is adaptive and an iterative process that is responsive to the needs of the user groups to improve the design and the delivery of these resources. I have had some people tell me that they consider what I do to be a very discovery-oriented process, and I think that that's a pretty accurate assessment of my work. As far as analysis, obviously, I use appropriate analyses at all time. Particularly, I let my quantitative and qualitative experts support the design at the more intricate levels, while I support the conceptualization of my analysis. But I think it's really important to note that we use rapid content analysis quite often in our human-centered design work because it gives a quick turnaround for data, and it helps us take a rapid iterative approach to understanding what's happening and how we can be most responsive to what we're finding and get that those findings back to operations and clinical partners as soon as possible. I think it's very important to note that the reason why I associate myself with the discovery process is because in traditional science, you had a protocol that you proposed, it got funded, and traditionally you did that protocol. It is very common for my protocol to have to be adapted in kind of mid-swing to make sure that our needle moves with the needle that is driven by the operational and clinical needs of a project that I am engaged in. So very often what we propose is almost like a hypothetical blueprint. And then once we get into the muddy waters of what we're doing, we discover all kinds of fun things that give us challenges, present opportunities, and sometimes barriers that we need to adapt to remain relevant. Is a very important part of our work. Before I move on to my completed work and my projects that are wrapping up, would anybody like to ask a question or make a comment about my approach to research? Okay, we can always talk at the end as well. So here's a quick overview of some of my virtual projects that I have completed or I am wrapping up at this time. You'll notice that several of them relate to secure messaging, and then one is around the veterans' preferences for interacting and using multiple platforms. I have been also funded to establish protocols, regulatory processes, and contractual processes for doing electronic patient-reported outcomes outside of the VA network. And then also implementation strategies to promote clinicians' use of virtual resources. And I'm going to talk briefly about each one of these projects. So the veterans' experiences using secure messaging. So the VA has this thing called the query, and it is their funding mechanism for implementation work traditionally. And in the past, they were centers. This is not how it's structured now, but 10 years ago, this is how it was structured. And they were very disease specific. And then along came the last, I believe, last funded query, which was called the eHealth query. And I was coming into the system as a scientist at this time. And I was one of the first scientists to be funded with the new emergent eHealth query. And I was funded to look at veterans' experiences with secure messaging. Now, in the big picture, what was going on is that it was a huge transformation initiative to get all primary care teams using mandated use of secure messaging. But we were running into a lot of issues with that. And I won't go too much into it, but user experience, workload credit, so on and so forth. And so they were trying to figure out what needed to be done to support the implementation of this mandate coming from the White House. And so I was the first one funded to do secure messaging. Other scientists were funded to do other projects with this first round. And I was also put in a position where the regulations and policies of the VA did not allow secure messaging to be accessed for research purposes. So before we could even do this project, we had to change the regulation and the permissions by all individuals signed up for secure messaging to allow that. And that was a policy change that had to be implemented before the project could even be done. So again, the clinical and operational partnership was critical before the project even started. At that point, once we received and changed the national policy, and every time a patient went into the secure messaging, a little pop-up box came in around the permissions, and they obviously would either deny or accept those new permissions to allow us to access their records. So what we did is we did a mixed methods project that was with 33 veterans. It was deep in scope in that we did interviews, usability testing with their experience with secure messaging, as well as follow-up interviews. And then we accessed all of their secure messages and did a content analysis of the messages that they had sent and received for a certain time frame. What we learned was that secure messaging was a very valuable tool that was very useful, but it was very useful for sensitive topics that veterans didn't want to address in person, which was a new finding that was unexpected. We also found that they didn't quite understand the difference between secure messaging and My Healthy Vet. It was a muddy interface to them that didn't have any distinction, which is very different from how we see it as clinicians in operations. And we also learned that there was usability barriers with navigation that warranted a redesign. And we learned that no matter how much they liked the tool, they would not use the tool without promoted and reinforced use by their providers. There's some publications that looked at the not only the findings that we found, but also we identified some personas of the different types of people who would be more likely or less likely to use secure messaging. So then I was funded to do a large scale survey. I ended up with 819 respondents. And basically this was just a survey study with another unique set of veterans to validate that smaller qualitative project. And it essentially did confirm the level of satisfaction, the level of need and uses for secure messaging, as well as the desire to use it for sensitive health topics.
Jolie?
Yes.
And I'm curious, I mean, how did VA's use of secure messaging compare to secure messaging systems outside VA? I mean, how did the experience, I mean, were similar findings reported with secure messaging outside the VA? I mean, can you speak to that?
So the use of secure email
Yeah.
It was at this time not common. You did have other networks such as Kaiser leading groups that were using it, that were finding that it was useful, valuable, but it did need to be a user-friendly system with ease of navigation. I do believe we were the first people to publish the use of it for sensitive health topics. Of course, if you say that, then somebody goes and finds a paper that came out before yours. But I do remember that actually made national press and got picked up because it was something that had not been seen previously. And this was for things like mental health, erectile dysfunction, things that people found, incontinence, that they found to be sensitive in nature. And it was really interesting though, because it caused somewhat of a debate, especially around the mental health issues, and even around some of the sexually oriented topics, because some clinicians didn't feel that it was an appropriate place for that type of communication. So we really had to do a lot of education and dissemination to help create a norm that this would be an opportunity for a specific use of this tool. So there was some new findings, but everything was relatively consistent.
Yep. Great, thanks.
And this is, by the way, the publication around that survey. Okay, so while this is happening, the undersecretary had a task force that was called to order to figure out how we were going to take all of the VA's fragmented systems, telehealth, kiosk, mobile health, the My Health Vet, the CPRS, and pull it together to create an integrated, standardized, synchronized system. So at that time, the Office of Connected Care was established. I was present as an asset, which meant I was allowed to be present, but I did not speak, and I sat in the corner of the room only as an observer with the eHealth Query Director. And then we developed this project, which was understanding veterans' preferences for exchanging information using VA HIT. What is notable is that when it was first submitted for funding, the reviewers came back and said, you are too broad in scope. You need to look at a singular virtual health resource and or system and focus on that. And at that time, we came back with a very strong response to reviewers suggesting that the future was an integrated network, a suite of resources, and that the fragmented evaluation of those resources was part of the problem, not the solution. So this was where we went in and looked at all of the VA's virtual resources, and we took what we called expert informants. This was very much an HCD participatory design, and we evaluated their preferences for using systems, what competitive systems were being used outside of the VA, and what needed to be done, what resources were most useful for primary tasks in health management. And basically, we created an entire process for creating process models, simulation, and design in order to inform operations and how they would move forward with doing this massive enterprise-wide integration, standardization, and synchronization. So just as to give you an idea of how we took basically the drawings that were done in these focus groups on walls, on tables, on printouts, we moved them into low fidelity electronic simulations, and then we delivered those along with these process models that my team and I created around certain tasks and what could be done with certain resources. We delivered them to an operational team called Human Factors, which is now within the Office of Connected Care. And we worked with them to create somewhat functioning modeling simulations. In other words, these are just screenshots, but these screenshots represented a redesigned interface that had pseudo functionality that we then went back to the same groups of veterans and said, is this what you meant? Is this what you wanted? Is this how you wanted it to function? And then they gave us their feedback, and largely we got it. We got about 98% of what they were talking about. The one thing that they did say that was kind of interesting is you see all these buttons. They said, do not put a button on a screen that doesn't have a link function. things like that. So that just a little bit of additive information. And I have a lot of these simulation screenshots because we did them for all real estates, kiosks, mobile, web. We have how we design the medication, the lab tests, so on and so forth. And that's how we did it. Now, what was really cool about this is it was all about timing, is that the VA was initiating a redesign while we were doing this in line with them. As remember, I talked about staying relevant for the operational timeline. So we had recommended a redesign of secure messaging in the previous project, and then we essentially supported the redesign of the interface of My Healthy Vet. And so we then became operational partners and consultants and supported the ultimate redesign of secure messaging and the My Healthy Vet portal that exists today. So you'll notice that it's very similar, at least the last time I checked, to what you see here. And these are the publications that came out of this. We created a protocol. We typically publish all of our protocols because we have found that a lot of our work is very helpful for replicating human-centered design approaches with mixed methodologies. We also created a matrix which went across the uses, barriers, how it could be used, how the virtual resources could be used by clinicians, how they could be used by the veterans, how they were being used now, how they could be used in the future. So it's a very broad spreadsheet with multiple sheets and with a lot of information. And then we also published the simulations and the process and how we created those simulations. So as you can imagine, a lot of this change creates education needs, not only for operations and clinicians, but for the veterans. So as MJ mentioned, I do a lot of multimedia direct-to-consumer marketing and education. And so these are a lot of the different videos that we've created with clinical operations funding and support. By the way, JAWS is the technology that is used to support individuals with visual disabilities in their use of computers and navigating computer pages so that they can essentially absorb all information that is on the screen through a audio narrative. Okay, so as you can imagine, I was starting to get a reputation for knowing how to do technology in the VA, which is kind of funny because sometimes I can't turn on my own computer, but that's besides the point. So I was approached by Ronnie Ilway, who was working with the Complementary and Integrative Health Evaluation Center that was funded by Query with Stephanie Taylor. And they were embarking on the whole health implementation evaluation with Barbara Bacour. And they had been charged by, I think, Congress to conduct one of the largest survey studies in VA's history, something like that, some landmark project. And they needed to collect thousands of patient-reported outcome surveys over multiple time points. And they had no compliant, regulatory approved means by which to do this at the time. So I was funded to basically find a way to create a protocol, a process, both regulatory and with a federally approved FSMA compliant system that could collect surveys outside the VA firewall. Long story short, we spent about a year and a half doing this. It ended up that Qualtrics was trying to create a FedRAMP FSMA compliant version at the time. I became a consultant and kind of a liaison bridge type between operations, research, and contracting, and the vendors that were trying to make all this happen. And we were successful in doing it. As a result, we ended up consulting for and with most people in the nation that are doing this, people in Palo Alto that were creating their own systems, people in Boston. And to this day, we are consultants. We support not only the protocols, but we also make our scope of works for our contracts available to anybody in the VA who's trying to get a contract to do survey studies with a third-party vendor outside the VA firewall. And basically, this is just another operational project that I've done related to virtual resources. And by the way, this turned out to be really timely because when COVID happened this year, a lot of people that were doing in-person interventions and delivery data collection needed to go to an electronic format. So this was really great timing. And by the way, this has also been published. So now to my kind of current and wrapping up work. I learned very quickly that we could make the system usable and we could make the system functional and navigation friendly. But if the clinicians did not promote the work, the use of the tools, that the patients weren't going to use them. So I was funded by one of HSR&D's implementation friendly IIR funding mechanisms, which is equivalent to like an R01. And I was funded to create an implementation strategy approach to supporting primary care teams' use of virtual medical modalities as an integrated system. And what we did is we went in and we looked at their current use patterns and we created a toolkit to promote their proactive integrated use of tools as a suite. And then we created one of the first protocols to look at secondary data collection across all of VA's virtual resources that can be collected. And what we learned and what we are doing now is we learned that the only real tool that was being used, tools being used proactively, were secure messaging, because we have experienced that cultural transformation over the last 10 years. But we also learned that they were using telehealth, but they weren't using them as a proactive integrated system of virtual care delivery, which was critical. And they actually couldn't even really speak to it in a meaningful way. So we ended up having to modify our protocol and interviewing expert and clinical informants at the operational level to get their vision for what proactive integrated use looked like. And we ended up creating a healthcare continuum, kind of from pre-appointment through the different appointment processes, post-appointment and self-care management. And we started to do kind of a plug and play of the different resources that could be used at these different phases of the healthcare continuum as a kind of a first stab at this approach. We also created an expansive toolkit, which Office of Connected Care has their own toolkit. And then we did a comparative analysis between their toolkit and our toolkit. And because ours was an environmental scan across all resources, we actually had a more expansive toolkit. So we're now working with Office of Connected Care to hopefully blend those toolkits and disseminate it for use. And then we are now collecting our secondary data and preparing to stage that data for analysis. This project does end in the spring, so we are still collecting that data. And what was even available when I proposed this project is no longer available. They've pulled a lot of the data sets out of CDW and out of the VSSC. This is where, sorry to use a lot of acronyms, we have a habit of doing this in the VA. So the CDW is a data warehouse, and the VSSC is a system of data cubes that have been created like a dashboard to access data easily and efficiently for the purposes of research. And so things that were even there then are not there now. So we have gotten what we can from these data resources through Vinci, and we have also collaborated with operations to get it directly from operations through our partnerships with them. So even though it is a blueprint, it's a little bit messy, but it actually is going to be a great publication, because we are excited to publish the fact that it is not a conducive process to collect and analyze this data right now, and that the VA needs to put more effort into making this data accessible in a way that can be useful to drive research and clinic operations. So I'm actually, it's not fun for me, but I'm really excited to set the stage for that kind of initiative and to demonstrate the need. This is our protocol that we published, but the other manuscripts, there's one is in review and a couple are in development, because as I said, this is ongoing work. Okay. As I mentioned, the outcomes of this project have been very dynamic. We've developed a toolkit with a lot of training tools that have actually been used for the intervention that we conducted. And we've done videos around this proactive integrated approach with some test and kind of case scenarios. And then we've developed the blueprint. So here's what's really interesting. We did this project over the last few years. Our implementation intervention was in December of 2019 and January of 2020. So just process that, let that settle. So what that means is that we did our intervention and then the entire nation was reliant on virtual healthcare to deliver remote healthcare delivery due to the pandemic. So it was awesome because it makes my data look incredible. It looks like my intervention affected the entire nation. But it was also horrible because obviously that is a confounding variable of epic confounding variables. So what we have now decided to do is we're going to use our data to demonstrate the change in virtual health resource use pre-post COVID. And so, of course, it obliterated our project as far as that goes, but AIM-3 will be useful for demonstrating the changes in pre-post COVID. So I'm going to move into my current work really quickly and wrap up my presentation so that we can talk. So my current work right now is regarding around 3 really big projects. Understanding and responding to caregivers' electronic resource needs for delegation implementation, which is the VA's delegation tool, which allows a caregiver that is identified and approved by the veteran to access their electronic health record and to advocate for them and their care. And also, like, for example, have their own secure messaging account. I have an RCT that is delivering a web-based self-directed integrative health program for veterans with pain and PTSD and their partners to give them a remotely delivered education program to teach them how to do things like partnered massage and meditation, relationship building, and so forth. And we're looking at their usability and experience with the intervention as well as outcomes. And then I have a significant amount of funding through my whole health service with several projects that are virtual health related. As I mentioned, I'm sorry, the talking has got my throat dry. We are doing a usability study with the implementation of delegation, which is being done through the IAM group, which is Information Access Management Group, which is another operations group that's working with Office of Connected Care to implement this tool. It will be the mechanism that will be used during the Cerner transition, which is the modernization of the VA record. But right now it's being implemented through kind of the My Healthy Vet mechanism. And we're working with the veterans, the caregivers, and operations to evaluate the usability of the system, which is right now not very usable, and to improve the system so that it will allow users, sorry, to register and access the system. We're also doing a large RCT with 3 sites to look at pain and PTS management outcomes through this mobilely delivered CIH intervention for veterans and their partners. It is at 3 sites around the nation, but what we're discovering is its remote access is actually hitting the majority of states. So it's actually becoming somewhat of a nationwide trial. And then these are
Dr. Haun, this is Adam Gordon. If you want to take a break for a second just to clear your throat, that's fine. We don't want you to collapse on us.
Oh, it's okay. You can hear it going. My throat's going. These are my whole health.
Do you need an inhaler? Do we?
It's COVID. No, just joking. I'm joking. That was a bad joke. Too soon. Too soon. So these are my funded projects through Whole Health. And both of these top projects are evaluations of whole health programs that are being delivered through a shared medical appointment. And the need to revitalize shared medical appointments post-COVID on a virtual platform that was user-friendly became very apparent very quickly. We also have a local and VISN-wide funding to disseminate and collect the ePromise 10 for individuals who are using whole health electronically. And I'm also conducting, you could call it a meta-analysis, but it's more of a meta-environmental scan around what has been done since 1990 in the delivery of complementary and integrative health using virtual resources. This is an expansive funding that I have of 3.5 FTEs, where I initiate these projects in alignment with the priorities of my whole health service chief, and I run the research and quality improvement whole health program out of James A. Haley. So these are only 4 of probably 7 or 8 projects, and these are the ones that relate to virtual health delivery. These are some proposed projects that I have in review. Actually, the one at the top was just conditionally funded by ORH, the Office of Rural Health, which is evaluating the implementation of a whole health oriented telepain program. I'm not the PI, I am the implementation evaluator. The PI is Michael Singer out of Atlanta, but this has kind of become my thing with implementation, whole health, and virtual health. So people will contact me and I collaborate with them. So I'm not always the PI. And this one I am not, but I do have a significant amount of funding to do the implementation evaluation on this project over the next 3 years. And then the 2 projects that I have just submitted like a week ago, along with the one that I did with MJ and Risa, is I'm taking the work that I've done with all of secure messaging and the most recent one on the implementation with PACT. And I'm identifying super users and describing their use patterns to create a cultural norm of super use, as well as the virtual shared medical appointment evaluation, not only just for implementation, but I believe the future of virtual health, particularly with shared medical appointments, is not just making them possible, but using them as a venue for creating a sense of community. And that to me is the evolution of using shared medical appointments virtually. So this is my work, and this is the big picture. So I'm gonna let you guys talk for a minute.
Yeah, Jolie, this is Adam Gordon. Why don't you just take a break for a second? It's going to take a while for people to process this slide anyway. Take a breath, take some deep breaths. We don't want you to collapse. I've got 911 on the phone right now for you. So thanks. Just hang on a second.
But she's in an undisclosed location, so. We do have a couple of questions on chat, I see.
Yes, we have a few questions on chat at this point. Okay. Jolie, these refer to different parts of your presentation. So it might mean stepping back a little bit, but Jory Butler has asked, could you speak broadly about what might be the broader implication for combining toolkits, and how does this inform work outside the VA?
So the worst thing that can happen is a fragmented approach that dilutes our efforts to create adoption and sustainment of anything that we're implementing. And the best thing that can happen is that we collaborate, combine, and add fuel to the efforts as a cohesive, comprehensive effort. So for me to do my toolkit and for Christine Armstrong to do her toolkit and us to be doing these very much overlapping tools, but to miss opportunities to combine them and to empower the thrust of their impact with different presentations and dissemination efforts. That is the value, in my opinion. I think that part of the reason why I do so much dissemination with my protocols and my screenshots and my simulations and my toolkits is because I do believe that the VA, along with other select groups like Kaiser, we are leading the nation in virtual health delivery. But it's also really important that we maintain that with that status. And so I want to be a part of the exposure that the VA has, especially with the modernization efforts, to show that we are the head of the curve and that we are creating something that is worthy to take notice of and to even use as a blueprint or a reference for what other people are doing. Obviously everybody's catching up because of COVID, they have to. So the idea is to combine efforts and to use each other's momentum to create a dynamic, momentous effort to get what we're doing not only out to the VA nation, but out into the world so that we can have the greatest impact.
Jolie, thank you so much. That was a really great answer and just a discussion. We could probably talk more about that whole idea that you described. Debbie Passy also has a question. In fact, why don't I just turn the mic over to Debbie to ask it?
Hello. Yeah, thank you. Good presentation. So with the mobile and web-based interventions that you're discussing, do you guys have a way that you track any of the adaptations you make to the program, in reference to what you find with the vets? Just general question about adaptation, because it's something I'm interested in and it's been on my mind a lot.
So I'm interpreting that question as the delivery of the self-directed integrative health program for veterans and their partners for the mobile application that we're evaluating. So we have multiple means for tracking and adapting. One, the creators of the project are consultants. The creators of the app are consultants on my project. We are doing qualitative interviews that are looking specifically at use and usability. And we are doing presentations with those creators, and they are working with us to kind of prioritize and determine what they will be doing, because we're getting really good data on what's needed and what can make it a more useful tool. And so we're working with the creators directly. We're using the qualitative inquiry to make the recommendations. And other than just user issues around, it's just very simple design changes that might prevent use now, I think the creators are going to use the recommendations for a next version after the project. We've talked about the benefit of doing them now versus later. So we also are doing use data of the tool itself and the tracking data that can happen with the mobile app to look at use time on screens, things like that. So we're also using that data as well and summarizing that as well. So we're using qualitative and mobile user data. And then of course, we'll have the outcomes data that looks at their outcomes, but we're using all of that and we're using it in collaboration with the creators to inform adaptations that will happen somewhat incrementally over time.
Thank you very much. We have a couple more questions. Would you like to get into them? I'd like to have at least, both of the next ones, if we could get to them before the end of the time. Jolie, does that fit for you?
Sure.
Great. Valerie Vaughn, you have a question. Would you like to unmute yourself and ask it?
Yeah, sure. Thank you. Great talk. I noticed that you mentioned a couple of times that one of the key ways to promote veteran use was to have their clinician, their provider, kind of promote the use. And I was just wondering, you said you had to go back and do education. Was there a specific promotion you had to do to, show the value of this to clinicians instead of it just feeling like another thing to add to their long to-do list?
So I've been doing this for 10 years, and secure messaging is like, I can't stop referencing it, even though it's like, like 8-7 years old. But when secure messaging came out, there was usability issues, there was workflow issues, there was workload credit issues that really stunted its adoption. And it was through concerted efforts with research, operations, and clinical practice that we were able to, for example, redesign the system, implement workflow protocols, and more, and probably most importantly, get workload credit implemented. And so it's these kinds of things that are required from a multimodal perspective to create this change. So like, for example, I talk with operations now about how do we create workload credit for this proactive integrated use? Because we've seen from secure messaging that the systems need to be usable, they need a workflow protocol, and they need to get credit. And these are the kinds of things that have to happen. And so what the education, it's kind of two-way. We give them the value added and the test cases, and they tell us, well, this is specifically what we need to do in the delivery of care. And then we create kind of a workflow process that it's everybody's needs get met around giving the clinician a tool that's useful and beneficial, and giving the veteran an experience that is beneficial, and then making all those user groups aware of that. But then it also helps us identify opportunities such as workload credit, and then take that back to operations. And that's the one thing that we preach about a lot when we are going to the clinicians and the veterans, is we are not doing this for the sake of research. We are doing this to educate operations just as much as anybody else, because they've got to make the changes to make this stuff useful and usable. And that's kind of where that whole education process happens. It's kind of education for everybody.
That's great. Thank you.
Well, Jolie, thank you so much. We're getting close to the top of the hour, and then we have the tea time, which is the half hour coming up. So Adam, do you have anything to add here? Otherwise, I'll close the session and we'll move into the tea time.
No, I just want to say thank you, Dr. Haun, and a great presentation, but also I want to thank everybody for participating today. It's been a really nice introduction to implementation science, and we look forward to a successful forum going forward in the new year.
Thank you for having me, and sorry about the cough. I haven't talked this much in a while. And by the way, I'm very verbose. So if you didn't get to ask a question because I took too much time to present, please feel free to contact me.
And we also invite all of you to stay for the tea time.